Welcome back to Critical Care Survival Guide. We're going to review some common oxygen delivery devices in the next few minutes. We're going to start with nasal cannula. We're going to move into Venturi mask. Then we're going to talk about non-rebreather. Finally, we're going to work into high-flow nasal cannulas and heated high-flow nasal cannulas. We'll finish up with CPAP, BiPAP, and just touch on ventilators. So let's begin. For starters, the nasal cannula. One of the most common ways to deliver oxygen in the hospital. You've seen this. It's a cannula, a thin catheter coming from the wall. Patients wear 2 prongs inside their nose. These nasal cannulas go up to about 6 liters. And you probably learned, like me in medical school, that for every 1 liter coming from the wall, you increase the FiO2 by about 4%. So assuming room air is 21%, if somebody goes on 1 liter nasal cannula, you could assume that they're getting 25% FiO2. Up to 6 liters, 45% FiO2. There's one catch. The catch becomes when the patient starts increasing their own respiratory rate. When they're getting tachypnic, when they're pulling higher flows at a higher rate, the patient's own flow rates may exceed that of the nasal cannula. Let's say, for example, the patient's pulling 500 cc's with each breath, but they're breathing at 20 to 30 times a minute. Now they have 15 to 20 liters per minute of flow that they are generating. It's safe to say that that 6 liters of nasal cannula that you think is doing 45% FiO2 is being diluted out by extra air from the room because it can't keep pace. It can't keep up with a patient's own flow demands. So that's one limitation of nasal cannula oxygen. When that occurs, you might try something else. The next thing people typically do is called a Venturi mask. Venturi masks work by connecting to the wall. The air comes in at 100%. It travels through a plastic catheter or regulator that has a small aperture in it. Then it goes up through a corrugated tube and into a face mask to the patient. Each color plastic catheter has a different size regulator in it. As you change from one catheter to the next, you can increase precisely the FiO2. That air that's coming from the wall is 100%. It goes through the regulator. After it passes through the regulator, the patient, as they breathe in, entrain room air that mixes with that oxygen to deliver a precise FiO2. At the patient's nose and mouth, where the face mask is, the flow rates are generated by the patient. The high flow is not generated from the wall or from the catheter. It's the patient's own flow. They are sucking air into their lungs. The flow rate's generated by the patient. If somebody does not get enough oxygen from a Venturi mask, you might consider a non-rebreather. Here's what a non-rebreather looks like. It's a mask a lot like the Venturi on the face, but you see a bag on the bottom. What happens is as oxygen comes from the wall, it's pumped into the bag and the bag inflates with oxygen, pure oxygen, 100%. As the patient exhales, air, carbon dioxide, goes out the side ports of the mask. When the patient takes a breath back in, they don't rebreathe their own CO2. They breathe pure oxygen from the bag. This enables us to deliver much higher FiO2s. Like a Venturi mask, the flow is generated from the patient. One thing you want to watch out for in a non-rebreather is that as the patient breathes all the way in, you don't want to see the bag completely deflate. Because if that's happening, it means they're probably not getting all the oxygen they should be. You need to turn up the flow rate to the bag so the bag fills up completely between breaths. All right, now to move on to the high-flow nasal cannula. Sometimes you even call this the heated high-flow nasal cannula, depending on the manufacturer. Here's how these work. These are a bit different in that while oxygen does come from the wall of the room, it goes into a machine that infuses humidity, which is great to prevent nosebleeds and increase patient tolerance, but it also increases flow, such that now the oxygen going from the tubing of the machine to the patient's face can be pumped in at a higher flow rate. This does many good things for the patient and can improve oxygen delivery. A good mnemonic to remember this is high flow, H-I-F-L-O-W. H, it's heated and humidified. This prevents nosebleeds and increases patient tolerance. I, it has a higher inspiratory flow. This prevents the dilutional effect that we just covered with a nasal cannula. These high flow nasal cannulas can keep up with the patient's flow rate, especially when they get more tachypnic. H-I-F for flow, F is functional residual capacity. Because we're pushing air in at a higher flow rate, we can derive or develop a bit of PEEP, positive end expiratory pressure, This increases functional residual capacity and can improve oxygenation, splinting up in some of those smaller airways. HIFL is light. These catheters are light. They're very easy for patients to tolerate, particularly with the humidity. FLO. What is O? Oxygen. The oxygen diffusion and aeration is improved because you don't have the washout effect from the patients entraining all the extra oxygen from the room. The high flow nasal cannula enables the patient to keep up with those oxygen demands with their breathing high respiratory rates. W is washout. As the patient breathe in, breathe out, that oxygen, because it's under high flow, creates a reservoir, as it were, in the oropharynx and in the trachea, so that when the patient breathes their next breath in, it's full of more pure oxygen, much like the non-rebreather we've already covered. High flow nasal cannula. Next, we'll talk briefly about CPAP and BiPAP. You're familiar with these. We use CPAP for obstructive sleep apnea. It's a tight-fitting mask. Pressure comes at a high flow rate right in the face, and it splints open the airways. It also splints open the posterior oropharynx to prevent the collapse that we see with sleep apnea. It can also push air out of the alveoli in heart failure, for example, to improve oxygenation. BiPAP works similarly, but we have increased inspiratory flow rates. BiPAP can help augment ventilation. So your patients that have COPD exacerbations, for example, you can give them a higher minute ventilation, help them work to breathe off that CO2. Again, tight-fitting mask, and be careful, pay attention to their tidal volumes when you set them up on that. Finally, the ventilator. We have other videos about ventilators. Ventilators can do it all. They can deliver oxygen at high FiO2s, they can do it with a high flow rate, and you can deliver tons of PEEP to improve oxygenation. Thanks again for watching Oxygen Delivery Devices on the Critical Care Survival Guide. Please do subscribe and let us know what other videos you'd like.